am covering what happens to every patient/person that is dying at end of life, and sharing the methodology and approaches to care planning that I use and instituted in my hospice and palliative care experience to really ensure that things were as seamless as possible. And when they were in use, I found them to be very helpful and ensured palliation for patients. And it covered other aspects of their care to really ensure comfort and all around good holistic care. So let's get into that today. Just for a really, really quick recap, I want to review the 4 things that happen to every person that is dying at end of life. And again, I really found this very helpful when it was utilized and utilized accordingly. And all of this was this kind of methodology and this kind of framework that I used when I helped my staff with care planning all came from my 15 years of experience and trial and error, and really seeing what the needs were over and over of, the standard hospice patient and the issues that come up at end of life. For clinicians, this is really, I think, very valuable to you. You need to I will always preface this by saying, follow your policies and procedures, follow your physician orders, but this is what has worked very well for me as a clinician, and also as a person that was a director and worked really well for the staff and their care planning. So just a very quick brief review that we covered in part 1, which was the intro, of this video series, of a 4-part video series. Every single person who is dying will do 4 things. And number 1, they will cease to be able to take anything orally. And that is what we're going to cover today. We'll get into that. They also, at a certain point in their decline, they will no longer be able to take care of themselves independently at all. And they're going to rely on another plan to ensure that they are getting all of their care needs met. Thirdly, they will no longer be able to make decisions on their own behalf. So we need a plan for that. And then lastly, they're going to have symptoms, end-of-life symptoms, specific to their principal diagnosis and related diagnoses, related and unrelated diagnoses at end of life that are going to come up that we need to prepare for. So in today's video, I will be talking about the first thing that happens. And this is probably, I'm guessing, one of the longest ones, and it's going to be a little bit more technical, probably a little bit more directed to the clinician, but really something that I like to talk to family members and loved ones and non-clinicians about, because it really helps to have them understand why we're making the decisions we're making, so that they can really understand what happens at the end of life and what happens when, their loved one, the patient, is no longer able to take anything by mouth. So let's get into the first part of what happens when a patient is declining and dying at end of life. I really like this aspect of the care that I'm about to cover and discuss, because it's something that, again, I really worked hard with my staff, my previous staff, to instill. And the thing that I love the most is I really felt like I had, amazing staff with whom I worked in the last 15 years when I was in the States working in hospice and palliative care. I am abroad now for the next few years, so that's why I'm no longer doing it. But I also had just really smart staff, and once they grasped this concept, it was just really cool to see them be so good and so proactive at getting things and orders in place in the care plan to ensure their patients and families and caregivers really understood what was going on and ensure seamless care. Let me tell you first, before I get into this, what kind of drew me to really think about what is going to make the most sense, especially from a medication standpoint. So what happens at end of life as someone starts to decline, and become weaker? They eventually cease to be able to take anything orally. So it means they can no longer take, pills orally safely. They can no longer take food safely. Now, food is a different topic where we actually go into the comfort measures around there, and where we really weigh the comfort versus the risks. That's another topic for another day. But for this purpose, we're talking strictly about medications. And I want to just give you a couple of examples that really started to put a little red flag in my head about we've got to do better than this. So this always, emergencies always happen, as you know, maybe as a nurse or whatever, as a clinician or anybody that works in medical care. Emergencies seem to always happen around 3 a.m. in the morning, especially in hospice care. So what happened is I remember this period of time when I was a newer director where we had these calls in, the early mornings of the hours where a patient was experiencing a grand mal seizure. Now, if anyone has not seen a grand mal seizure, that can be it can seem like a very abrupt, uncomfortable thing to see. Even as a clinician, even if you've seen it before, you probably haven't seen it a ton, but even if you've seen it before, even when you see it, it's a hard thing to see. And the reason why that happens is because the nervous system, particularly in the brain, is not able to remain calm, cool, and collected. Some insult, whether it be dementia, whether it be a traumatic injury like a head injury or a stroke or previous stroke, something like that, brain tumor, something has really influenced and injured that environment and set it off from its standard homeostatic environment. And what happens when that nervous system is overwhelmed, it starts to fire like crazy. I'm just using kind of real simple language here. And you start to see the effect of these firings that are happening in a really kind of overwhelming way. This results in a seizure that is called a grand mal seizure. There are many other types of seizures and they look different, but for this purpose, these particular examples, it was the grand mal seizures that really kind of hit home. And I thought, this is I know these things happen unexpectedly, but we can do a better job, particularly when we know that we have some other information to work with. So these grand mal seizures look like the whole body is shaking and, the person is unconscious though. So that's another part that is a little bit difficult to kind of stomach and watch. So the person is shaking, and one of the ways, in one instance, so one way that the nursing facility knew that it was happening is that they heard the bed shake from outside the room. So the bed was shaking from outside the room because the person was shaking. Now, I just want to, again, clarify that these things can happen out of the blue simply if you are declining at end of life. Sometimes we know that these things could happen and we can prepare, and that's what I'm going to talk about today and in my other videos, of course, because we talk about how we can die better here at end of life. But sometimes they do really happen out of the blue, particularly, in these cases where nobody has had any kind of history. So what happened in several of those cases, and these are over, again, the first several years, when we looked at, when I kind of went back and looked at, what was going on in these instances. A couple of them were really out of the blue, but a couple of them, when I went back and I looked, I saw that the person became NPO. And for clinicians, nurses out there, that they stopped being able to eat and drink. So the facility, someone got orders to stop all routine medications and just do comfort medications only. And in those cases, the comfort medications, like we have a comfort kit, I mentioned that in another previous video, where, you have these standard medications, morphine, Ativan, bowel medications, things like that, things for temperature. And you can have those, but they're as needed, meaning that they're not routinely scheduled. So you give them when they're just needed. Routine medications, when they're discontinued, you're discontinuing them, completely. And in cases where the person is no longer able to take oral medications, that's a standard that I know before, especially, that was a real standard practice that you just get the orders to discontinue, because if you as a nurse cannot give a medication because the patient is no longer able to take the medication safely, you in your scope of practice need to contact the doctor and get the appropriate orders. And oftentimes they're discontinuation orders because you're not able to proceed with that action in the plan of care. And what happened is, so in these cases, the patient no longer received their routine medications, and they were on anti-epileptics. They were on seizure medications. Did not receive their medications for that day or maybe a day and a half. And then what happened subsequently, as they went into a grand mal seizure that evening. Now, you can probably start to think about, oh gosh, well, had we known, if you looked at the medications, maybe could we have done something different? So this is where I started to get down on a roll, and not just looking at the obvious pain medications that you take by mouth, but really looking at other medications that you take by mouth. So I really find this interesting, and I really like this topic because I have seen it work so well when it was implemented, appropriately and properly. So kind of groups of medications that typically, you look at and that I think we want to pay attention to. The obvious ones, particularly in hospice care, are things like your pain medications. So what you want to do with your patients and your med list is you really want to look at all the medications. You're thinking, well, duh, Abigail, I know. Okay, look at every single one of the medications. The obvious one is a pain medication, but then there's some that are not so obvious that I want to get into, that I promise. And those are really key to keeping the patient well palliated. You want to look at every single medication. Let's start with just the classic pain medication. Say the patient is on, 30 milligrams of MS-Contin twice a day. MS-Contin is in a pill form that you take, and typically you can take it anywhere from 12 to every 8 hours, depending on the needs. Obviously, this is all, individualized and based on patient need. And that medication is given and the patient swallows it. What's really important about MS-Contin is because it's long-acting, you can't crush it. You can't, things like Kadian, it's also morphine. You can't, obviously crush that either, but you can open up the capsules and try to take it, with some jelly or something like that. That's a whole other thing for another day. And so when you have these pain medications and you can no longer take them, a patient can no longer take them orally, you can, many medications you can give them rectally. You obviously, of course, as a clinician, you need to get orders for this. So many times, what I would do as a clinician or as, coaching my staff is I would say, okay, so we have orders. We know the patient's maybe weeks, maybe months away from becoming NPO. Bingo, we've got this, routine long-acting pain medication, and you can use this example for any pain medication. And so we know what the dosage is. Okay, great. So what are we going to do to ensure that when the patient becomes NPO, that when the patient can no longer take that oral medication, what are we going to do to ensure that the therapeutic levels in the blood remain the same? Basically saying to ensure that, any transition is seamless and the patient remains comfortable. And in order to do that, we got to ensure that there's no interruption in the therapy, right? We got to make sure there's no interruption in that pain medication delivery for that patient. So we really want to make sure that just because a patient can't take the pill anymore, that we just, we don't just stop the pain medication and just, give some Roxanol drops whenever is needed. Now, what happened, when we had, some kind of growing pains around this, what happened before, what I've seen happen before, and I'm not just saying in my experience, but just for other even providers is, sometimes they would get orders to, once they stopped, once a patient was no longer able to take oral medication, someone would get orders to just do routine Roxanol. I have an issue with that, particularly if the patient was on MS-Contin. What you want to do, first of all, is look at the amount of morphine the person is getting. In this case, again, you can use it for many other types of medications, for pain medications, but look at the amount of morphine. So say in this case, we had a patient that was getting 30 milligrams of MS-Contin twice a day, 9 a.m., 9 p.m. Okay, so their total amount of medication 24 hours is what you want to look at. That's 60 milligrams of morphine in a 24-hour period, okay? And so what you want to ensure is you either transition them to a rectal form of administration, so the MS-Contin can be given rectally, and you don't necessarily need the gel caps. I know pharmacies a lot of times, have you also purchase the gel caps. You don't necessarily need those. If it's easier and you have more assurance of your administration and it works better, by all means, again, follow your orders, follow your policies. But say, the patient is also getting some drops of Roxanol here and there. So you want to look at that point, the last 3 days, and look at the total of amount of morphine that the patient has been getting in the 24 hours. So then you would add, say the patient got another 10 milligrams of Roxanol, each day in those 24 hours. So that's long-acting morphine, 60 milligrams in 24 hours, and then another 10 milligrams of short-acting morphine. So now you're adding up to, 60 plus 10, 70. So in that case, you might do 75, whatever it is. You find the correct pill form for that, and you can give it rectally, okay? There is a big point here that I'm going to make in just a moment. Now, sometimes patients and families, families in particular, they're not really crazy about giving things rectally, and it all depends on how you approach it. And I found that when we went to patients and we're like, we have to give it rectally, we need to just kind of dispel any kind of concerns there, because you can give something rectally and still make it comfortable for that person. You don't necessarily have to even roll them over onto the side necessarily to administer. For males in particular, it's fairly easy once you lift the testicle sac, and you can easily administer the pills rectally that way. For females, yes, you do have to maneuver a little bit, and depending on contractures or not, usually doing it on the side is a little bit more easily done. Now, sometimes, when you get to that case, in order to minimize any kind of discomfort, related to repositioning, particularly, depending on the times of repositioning, you can switch in this case, that we're using long-acting morphine, you can switch to another longer-acting morphine like Kadian, and just give the Kadian rectally once every 24 hours. So in that case, you'd be giving a Kadian, a pill dose of Kadian that's a little bit larger depending on the amount of morphine the patient has been receiving in the last 24 to 72 hours. And you look at that 24-hour period for those last few days to get an average and administer that Kadian once a shift. And at that point, depending on where the patient's located, if the patient's in a skilled nursing facility, the skilled facility nurses can administer that. If it's at home, the family can, or the staff can, hospice staff can certainly help. If it's something like a boarding care or a RCFE, assisted living, the laws are a little bit different there. At least, you can schedule, your staff to come out, a nurse staff to go out and administer every 24 hours. So that's just a very basic form of a basic example using the pain medications. The one thing I want to emphasize here, though, is don't wait until the patient becomes NPO. Don't wait until the patient can no longer take the oral medications. Please. What you can do especially after you administer that patient, after you admit that patient, say, onto hospice care, and you're having your IDT, the first couple of IDTs, and maybe you're a bit away from the patient becoming NPO, you can get an order for when the patient becomes NPO or no longer able to take oral medications. Of course, I know things change in the medical field, policies and everything are individual to each entity, follow that. But typically what you can do is get an order for once the patient becomes unable to take oral medications, discontinue the oral routine MS Contin and administer the routine MS Contin 30 milligrams rectally. That's just an example. And you can do that. And then that way, when the patient becomes unable to take the oral medications, you already have orders, you already have it in your care plan on your medication list to just transition to a rectal form of medication. Now, if this doesn't fly with your policies, I understand that sometimes that doesn't fly, then what you should do is you should be getting orders that when the patient becomes NPO, contact physician for updated orders or for new orders. And what I like to do, and what I've done, especially in these cases where some facilities weren't quite comfortable with the transition order immediately to per rectum, is I would say in that order, and I would have the physician ensure that that they gave me that order to detail, that call physician for new orders. I would have it in specifically to address plan with MS Contin or plan with whatever medication. Okay, so that kind of applies to all the medications.